Hello everyone, I'm Renee Mehrra and welcome to Your Health Matters, our innovative weekly series with healthcare experts providing their deep insights into critical health issues so we can stay healthy. Joining me today at Mount Sinai Health Systems, we have an esteemed panel telling us all about prostate cancer, the second leading cause of cancer death in men. And this is an important issue we're going to be discussing today. So joining me today in our esteemed panel is Dr. Ashutosh Tiwari. He's the System Chair of Urology at Mount Sinai. Dr. Eric Golubov, Professor of Urology at Mount Sinai. Dr. Raj Veer Purohit, Director of Voiding, Dysfunction, and Reconstructive Urology and Associate Professor of Urology at Mount Sinai. And Dr. Art Rastinahad, Professor of Radiology and Urology and Director of Interventional Urology at Mount Sinai. Thank you, gentlemen, so much for joining us today.
Thanks.
Dr. Golubov, let me ask you, we know that 1 out of 6 African men are going to have prostate cancer in their lifetime, and 1 out of 8 Caucasian men would have prostate cancer, would be diagnosed with prostate cancer. So it is a very serious issue. Tell us, when should men start paying attention to their prostate?
Okay, so that's a bit of a controversial topic, but in general, around age 50, men should start to think about whether they should be screened for prostate cancer.
Right.
And when you talk about screening for prostate cancer, you talk about what are the risk groups, who are the people who are at risk for prostate cancer. And those people are men who are African American, and men who have a first-degree male relative who have prostate cancer. And the earlier in life that your first-degree male relative has prostate cancer, the more at risk you are. So in those two groups, one would recommend screening or at least getting an initial prostate-specific antigen blood test somewhere in their 40s, certainly by age 50. Mm-hmm. For a man who doesn't have risk factors for prostate cancer, in general, the screening should begin around 50. Okay. But the recommendations are that not every man should be screened, because screening itself has risks. So every man should be talked about to have screening. They should weigh the risks and benefits in their individual lives and their individual health conditions before deciding whether to be screened. But in general, around age 50, one should begin to think about their prostate health.
So what tests and procedures do urologists take on for this?
So the most common test is called the prostate-specific antigen blood test. It's just a simple blood test, and the test spits out a number. And that number helps to give an overall risk of whether you might have prostate cancer. And there are many algorithms and many different ways of looking at it, but in general, the lower your PSA test, the less risk you have of prostate cancer, and the higher, the more your risk is, with a cutoff of around 4. So if your level is more than 4, or if it's rising over time, that puts you at risk of might having prostate cancer at the present time. Whereas if it's low and it stays low, your risk is much lower.
I see. So you talked about risk factors. So let's say if somebody is African American, so they definitely need to go for their test?
Yes, one would think that an African American man in their 40s or early 50s should be screened for prostate cancer.
What about South Asian men? Is there any risk factor involved with them, with that
I think family history would be important. Yes. If there were a family history. I don't think in general South Asian men is a risk factor specifically for prostate cancer.
So how many cases are caught early?
Well, I think we take a step back and say that probably around 180,000 new cases of prostate cancer are found each year. And of those new cases, one could probably say that 50 or 60% of them are caught quite early.
I see. So it's like half the number, which is
correct, which is
that
good,
bad news.
Which
yes.
means that we're probably doing a pretty good job of screening. But those other 40 or 50% of men who are caught later, perhaps you would think in your mind, had they been screened earlier,
right,
they might have a better prognosis.
So what type of surgeries are done at different stages of prostate cancer?
So let's take a step back again. In the men who are diagnosed with early stage prostate cancer, who are very slow growing, again, about 40 or 50% of the men who are initially diagnosed, those men don't need any treatment. They need to be observed. It's called active surveillance. And it's an extremely important point because even though you might be diagnosed with prostate cancer, it's not, for most of those men, it's not something that needs active treatment. It needs active surveillance. It needs to be watched closely to see if it changes over time, and then you might have surgery or radiation therapy.
Right.
But for the men who were caught very, very early, just watching them carefully is enough.
So when you said active surveillance, is it every 3 months, every 6 months, every year?
There are active surveillance protocols. Some protocols call for being seen every 3 months, some every 6 months. As time goes on, those intervals might be stretched out. And it's not just seeing the patient. It's getting another prostate-specific antigen blood test. It's examining their prostate with a finger. Maybe it's getting an MRI. Maybe it's doing another biopsy to make sure they don't have cancer. So it's an ongoing surveillance process.
So Dr. Tiwari, tell us about robotic surgery and why is it so effective?
I think first of all, we need to think who needs robotic surgery.
Yeah.
Because as Dr. Golibov was mentioning, about 50% of the cancers, they are very indolent and can be observed. Then there is a group of patients who have a Gleason 7 or a Gleason 8 prostate cancer, which has not gone elsewhere. It's still confined within the prostate. And that's a good candidate for what we call prostate-specific therapy. And that could be one kind of radiation or robotic surgery. We tend to prefer robotic surgery in patients who have a longer life expectancy, who doesn't have any obvious signs that the cancer has spread to the other parts of the body. And robotic surgery can be done as in same-day hospital operations. It takes about 2 hours to do that. Patients don't get a real big cut. Patients have a minimal blood loss. And since the vision is much more exquisite, patients don't bleed that much, they have a reconstruction, and they can go home next day.
I see.
But I must say at one point that it's not just the robot, it's how you do use the robot, because I have seen many great open surgeries. It's all about what you do. Robot health tends to help me in doing that, but surgery can be done both open and robotic.
And how many have you done robotic surgeries in Mount Sinai?
In my career, I have done close to 6,000 to 7,000 of these, and I think in last few years I must have done about 1,600 to 1,700 of these. So we have a very busy robotic program, but it's not about just how much I do. As a program, we do about 2,000 major cases a year, not necessarily on prostate, but different cancers and big things. And we do it open, we do it robotically. We have one of the best focal therapy programs, and we have one of the best radiation therapy programs. So any which way treatment needs to be done, we can handle it. And then at some point we can talk about those cancers which were already little spread, how to tackle them, and even for that we have a program.
So before we talk about that, let's talk about the nerve-sparing technique that you're very famous for.
So prostate happens to be an organ which was not meant to be touched by surgeons. It was hidden deep inside the body, and it tends to sit on a meshwork of nerves which were destined to go down to the penile tissue, and they control erections. They also control some other functions in the body, in that part of the body, but erections is the main thing which we talk about it. And at any given time, cancer cells are never more than few millimeters away from the nerves. So being able to save the nerves yet do the best in cancer control is a fine balance. Surgical skill helps. To me, robotic vision helps. To me, lack of bleeding helps. But I think the pre-planning, in which every couple of weeks, I'm calling my expert in radiology or MRI, Dr. Ashton is sitting here. Art, there is something I'm seeing on the left side. Do you think I should go ahead and do the nerve, or should I not? And he will look at it and he'll say, yeah, you can do a partial nerve sparing. So it's a beauty of a collaboration between the different mindsets and delivering the best to the patient. That's what matters.
So generally, the robotic surgery lasts for how long?
I can finish this operation in 2 hours, and patients stay in hospital just overnight. We routinely do it. Between all of us, we do about 4 or 5 surgeries every day.
I see. Wow. So we'll be back in just a moment, and when we come back, we'll be talking about ultrafocal therapy with our experts. Stay with us. We're back and talking to our panel on prostate cancer, the second leading cause of death in men. And Dr. Rastenhat, tell us about, you're one of the pioneers in ultrafocal therapy. What's this new approach?
What's exciting about what we do here at Mount Sinai is that there's some men that are not candidates for active surveillance. So they would like something maybe less aggressive than surgery, maybe a middle path to avoid the side effects of surgery, which could be leaking urine or not having great erections after the procedure. At Mount Sinai, we have focal therapy, which we do HIFU, which is high intensity focused ultrasound. Cryotherapy, where we freeze just a spot on the prostate. And what our research is specializing in is a new way to avoid the side effects associated with those therapies for an ultrafocal or really a refined approach to really optimize killing the cancer while allowing a man to have an outpatient same-day procedure with no Foley catheter in place at all.
So is it before or after the robotic surgery, or is it separate by itself, the therapy?
It's a separate by itself. It can occur before. It doesn't burn any bridges. So if you have the treatment, it's cancer control, not a cancer cure. And if there's cancer comes back, we don't think we really miss a window for a cure, and they can have a robotic prostatectomy with Dr. Tiwari with no more added difficulty.
What's the success rate for it?
Right now, the clinical success is about 75% of patients have success in a cancer, controlling their cancer today. We're in a phase 2 trial, which is really exciting. And what's exciting about it is compared to laser therapy we do, these particles get deposited right inside the tumors. And then we excite that with a laser fiber that just heats the particles, so it confines the tumors itself while sparing the rest of the prostate.
Yeah, the gold nanoparticles.
The gold nanoparticles. We infuse them and they circulate and deposit it within tumors.
Does one have to repeat this procedure?
It's a single treatment.
I see.
It's an outpatient procedure. Patients come in and go home the same day.
And so if it's not successful, what's the next modality of treatment?
So sometimes we watch the patient because there may be just a speck of cancer left, or they can go on to have surgery, radiation, or other focal therapies for cancer control, which we do the HIFU or the cryotherapy.
Right. So let's talk about the body-mind, and that's so very important. You know, it's always should be the body-mind connection. And what are the pre and post surgery things that one should be taken care of? And because sometimes the do's and don'ts, sometimes people are not clear about.
So I think prostate cancer happens to be in a body which is supporting genesis of that cancer. And the things which we know at this point, obesity, sugar, animal fat, and inflammation promotes cancer. While taking care of these factors, eating right, exercising, sleeping well, kind of controls the process. So on one side, we have one of the best healers in terms of either giving them a focal therapy or putting them on an active surveillance or operating if I need to, or helping them with the recovery of bodily function, what Dr. Rajveer Purohit does. We have different modalities available for patient to heal at this point, but then we are taking it to the next level.
Yes.
We are expanding our approach of treating this cancer by collaborating with experts like Deepak Chopra, who happens to be a friend of mine, and he and I share the same mindset that there is only up to a point we can heal by the medicines and knife, in my case.
Yeah.
There is a lot which can be done by controlling the body's inflammatory process, meditation, and other complementary approaches. We have a person in the program, Jillian, who is an expert of integrative medicine. And when you talk to Dr. Purohit, you will get a better sense as to what it takes for patients to heal their bodily functions. There is an art in it, there is a science in it, and there is a deep program which is built around that.
Yes. So Dr. Purohit, tell us, your side of how we can work this body-mind connection.
Sure. So basically, I look at two things you worry about with prostate cancer treatment. One is problems with erections, and the other is problems with leaking urine or incontinence. So one of the nice things at Mount Sinai is that we have, Dr. Tiwari, Dr. Galibaf, we have integrative medicine, we have everyone working together to try to minimize these kind of complications that can occur, both with the radiation as well as with the surgery. One of the things with erections, for example, we can do is I'll often see Dr. Tiwari's patients before surgery to start sort of having them plan for what to expect and also start proactively doing things to minimize the chances of erections. So we know that there's data that shows that if you start taking medicines prior to surgery, even after surgery may help you recover function. And we know if you're very aggressive about treatment after surgery for erections, then it'll help you in the long run retain your erections and also give you better erections in the long run. So many patients will be seen both before surgery and then they'll be seen after surgery. There's a whole protocol we have for managing problems after surgery.
So what other symptoms do you see at this stage?
No, the other things you worry about after surgery is incontinence or leaking
Right.
urine. And that could be, it's usually the kind of incontinence is called stress incontinence, where if you laugh or you cough, you leak a little bit of urine. The risk factors for incontinence are usually damage to the nerves or damage to the sphincter at the time of surgery. One of the nice things at Sinai is that we have experienced surgeons like Dr. Tiwari and Dr. Ghalibaf, and there's very good data that shows a high-volume surgeon has a much lower risk of these kind of complications from occurring. The other nice thing is that most patients can be treated, even if their incontinence persists and becomes a problem, they can be cured of the incontinence with additional treatment in the long run. So.
Is there any procedures for that? Or?
Of course.
Yes.
Yeah, absolutely. So there's a few things we can do to speed up the process. So one thing is starting patients on a biofeedback regimen, which is teaching them the right sets of exercises to do to help strengthen their sphincter. If the patient, in a very small percentage of patients this occurs, but if a patient is still leaking after surgery and it's been more than 1 year, then we can place an artificial urinary sphincter, which is a small cuff that you place around the urethra to give them continence back, or something called a sling, which gives them a little support on their urethra.
So you pull the muscle up.
Yeah, to tighten their sphincter, basically. So, and they're very high efficacy, so they work very well. So even in the worst case scenario, which is what I tell my patients, let's say you have problems with erections, or let's say you're having problems with continence, even in the worst case scenario, both can be cured and fixed permanently.
I see. We'll be back in just a moment, and we'll be talking to our experts on future outlooks in prostate cancer. Stay with us. We're back. Dr. Tiwari, tell us about the future in prostate cancer, about the role of genomics. You know, that's a big thing these days.
I think the future is being built here between
That's
youngsters
wonderful.
and
That's good
stars which
news.
we have in the department. Future is truly being built here, but I can talk a little bit about the genomic revolution which is impacting almost every disease. We are talking about precision medicine. But at the genetic level, each cancer is very different.
Yeah.
And if we can figure out how to understand what's happening at a gene level, we can possibly have a more targeted therapy for that patient.
Yes. So we're looking at genes, you're looking at the risk factors, and you're looking at different ethnic groups.
Of course
we talked about
Yes,
African men,
yes,
having
yes.
more, predisposition to prostate cancer. So this way you have a vaccine, you also have, the red flag right away. Okay, this person is from this race. Let's do more observation.
So what we call is then risk assessment or risk
Yes.
stratification.
Yes.
So genomically, we can tell a patient may have a same Gleason score, same grade of cancer, but may behave differently.
Yes.
And I'll leave that to be talked about by maybe Dr. Ghalibaf, who can talk a little bit of what are the classifiers we have which are genomic based.
So I think that's fascinating stuff, Dr. Tiwari.
Yes, it is.
But I think the outlook in prostate cancer, to me, the future outlook, is looking at the two ends of the prostate cancer spectrum. Is looking at the patients who are just diagnosed and trying to use our up-to-date advanced genomics and diagnostics to decide who needs to be treated. And then at the other end of the spectrum, the enormous explosion in basic science work that almost every day is revealing new treatments for prostate cancer. So to me, the future of prostate cancer is at the beginning and at the end in determining who needs to be treated, and at the end, what are the specific treatments we can offer to individual patients.
So what other MRIs are in the offing now?
I think the MRI discussion, one of the experts sitting in this room is right here. Maybe Dr. Rajnahed can weigh in into that.
With respect to MR, there's level 1 evidence that it improves screening or early detection of prostate cancer without question. There's New England Journal of Medicine, JAMA, and a lot of the work we've spent on with Dr. Tewari and myself, targeted biopsying. This is level 1 evidence that this improves screening. And it's superior or non-inferior to the old way of the trust biopsy without imaging. So maybe you can decrease the number of men undergoing biopsies, find more deadly cancers easily, and the threshold for having an elevated PSA, we move it down, we image more patients, so we're able to screen more, but we only really find the bad players because MRI's great advantage is its weakness. It doesn't see low-grade, low-volume disease. So we're completely changing the paradigm. As Dr. Golubov said, a lot of patients initially were diagnosed with a lot of low-grade disease. We don't have that anymore when we switch to imaging. It's completely flipped. About 70% of my patients that are positive have bad prostate cancer. Wow. So we're really changing this, how we approach prostate cancer. And imaging is the foundation of the future. And we compare that with genomics to try to develop these radiogenomic atlases to help better stratify risk.
Very fascinating. Tell us about this Man Cave Health Project.
I have to acknowledge Melina family, who has sponsored a Man Cave initiative at Mount Sinai. And basically, men take better care of their cars than their own bodies.
Even cell phones.
Yeah, I think so. They don't want to show up for the doctor's visits. They don't want to know anything, but they are most fearful when something really is found. And since the challenge is finding this cancer early enough in the patient who needs it to be found, key is there. So Man Cave is a new concept. Man Cave is a new initiative. Man Cave is an idea that men can come to a gathering, a place, a space, where at any given time they can come talk about things, and there will always be someone there who will engage them in these so-called sensitive questions. Questions about PSA, questions about sexuality, questions about fear, and how to get a right professional answer. That's the Man Cave concept. And people of expertise of Dr. Purohit can really relieve the mind of an anxious man who was thinking about the sexual function issues, who doesn't know who to talk to. And Man Cave is an opening in which they can come, sit down, talk about it, and possibly get some help.
That is great. What do you envision in the next 10, 15 years for prostate cancer? You're experts in this field.
We will be in a precision mode. We will have high-risk families identified based on the genomics. We will be doing more sophisticated imaging, MRI-based imaging, molecular-based imaging, special kind of PET scans will come. Even before putting in a needle, we'll know where and who needs an invasive procedure. There will be patients who will benefit just by observation. There will be patients who will benefit from ultrafocal or super ultrafocal therapies. There will be patients who will need everything removed. But it will not happen by one modality thinking that it can fix everything. It will happen from a multimodality approach. There will be a chemical approach, there will be a radiation approach, there will be surgical approach, there will be robotic approach. All that will coalesce together, and it will happen at a place where there is an open dialogue, open collaboration, and team members with an expertise in totally different ways.
So more integrated, more multidisciplinary.
That's right.
Yeah.
Not just by talking multidisciplinary, acting multidisciplinary.
And we're creating conversations here as well. I mean, This is what we're talking, so our viewers know that it's important to take care about their prostate. And what will be your final thoughts, Dr. Golubov and Dr. Purohit?
I would echo Dr. Tewari that in a place like Mount Sinai, where there's a lot of different people with a lot of different expertise, that's going to be the future, is a group of people with different expertise that come together in a synergistic way, that if they were alone, they wouldn't be as effective than if they're as part of a group, each contributing in a different way. I think that will be the future.
Dr. Purohit.
Sort of echo both of them as well. I think the treatment will become smaller as well as bigger in some ways.
Yes.
Smaller because we'll have fewer and fewer people dying from the cancer because of this very specific targeted treatment with fewer side effects. But I think we're also getting bigger in the sense of understanding that diet, overall health has a big impact on the growth of these tumors. And we're looking globally at the patient with this multi-team approach.
I have a question for you, Dr. Purohit. Where do you think stem cell therapies and nerve regeneration and all those fields are evolving? That's your area of expertise.
Yeah, absolutely. So I think this is something that's actively being researched right now, and I'm hoping in 10 years' time it'll be available to everyone, maybe even sooner, for both continents as well as erections.
Dr. Rastina, your final thoughts?
Oh, my final thoughts are always long and drawn out, but simply, what really excites me, Dr. Tiwari, myself, and other colleagues, we're starting a new fellowship to hopefully train new physicians in interventional urology. We've kind of branded it. The idea of this imaging, new approach to screening and treatment for men's health, taking the collaborations from our interventional radiologists, which I'm one of them as well, and bring that into one group. So we have diagnosticians, medical oncologists, radiologists, interventionalists, urologic oncologists, and urologists all working together to train this new breed of physicians. And that's what I think is really exciting for us, to allow to integrate these new techniques and as knowledge expands.
And I think the biggest takeaway here is that men, please take care of your prostate, especially if they are 50 years of age, and they should come for tests and procedures. Well, I want to thank Dr. Tiwari, Dr. Golubov, Dr. Purohit, and Dr. Rastina. And that's all for this week's segment on Your Health Matters. Stay healthy, stay positive. Until we meet again, I'm Renee Mehrra.